We can't hear you, Dr. Tobia.
Can you guys hear this?
Yeah.
Hello?
Yeah, I can hear you guys.
Do you have headphones in?
I
Oh,
can hear you.
hello? Oh, okay.
Okay. We're gonna run up getting a bunch of chairs here. Well, so be it.
The problem is if one of you wants to talk, there's gonna be like really bad interference, right?
Well, if we turn them.
Just don't unmute yourself, just talk.
Okay. that works.
Because otherwise it's gonna be
Try it.
really bad. It's gonna
All
be
right.
really bad interference.
Let's give this a shot. All right. So Seinfeld, the Doorman. Where to start?
Is it unmuted on yours?
It is unmuted.
Okay. So something that I thought was interesting that we touched upon with the previous episode was Frank, I believe his name is, having paranoid personality disorder. And and interestingly, you kind of saw some of those characteristics in George when he was thinking about the gynecomastia that his dad was experiencing and worrying all the time that other people around him were also noticing it and that he was developing this gynecomastia. So you kind of saw that personality disorder characteristic kind of transferred to him.
In George, right?
Yeah.
All right. So let's talk about it. So now we're focused on George actually becoming preoccupied with potential gynecomastia, right? Any other behaviors surrounding this preoccupation? And here, preoccupation is simply defined as abnormal thought. We'll kind of leave it at that, similar to an obsession, similar to a delusion. Any other behaviors about George in this episode that you think linked to this? That you thought were funny, that you identified or observed or otherwise want to talk about?
A few things that I had noted down is that he had just mentioned that he was crying all night about the gynecomastia, I guess about related to his dad, I think at the time after he saw it. And then like the scene in the diner where him and the woman are wearing the same shirt. And she's like, look, we're twins. And he's like, why would you say that? Why did you say that? Thinking that she was talking about having breasts.
Yeah.
She's talking about the shirt.
Yeah, I mean, I think if you didn't already come to the conclusion that George was WAS preoccupied. That scene in the diner, I think, nails it and clinches it for us in terms of it being on his mind, because a neutral statement like that was personalized. And that is characteristic of somebody with paranoid personality disorder, that individuals interpret neutral statements as attacks on them, usually attacks on their character, but you can see something very similar here in the dynamic at that diner in that discussion. All right, so there are in fact aspects that are shared here with paranoid personality disorder. The other part of this too is that this kind of meshes with the general theme of egocentrism, which we talked about again last week. Remember, we talked about the film Seven, and we discussed how the 7 deadly sins are nothing more than the 7 personality disorders that cluster into B and C. Gluttony is a gateway, and gluttony's equivalent in psychology and psychiatry, egocentrism itself is a gateway. It's a risk factor. And George is egocentric. He personalizes his father's ailment. I mean, if his father did have gynecomastia, it was true gynecomastia, from a clinician's perspective, what might be causing this?
Decreased testosterone.
Decreased testosterone. How?
Increased like fat cells can cause like aromatization.
Right? Increased deposition of fat cells. Okay, so you're an internist. What do you need to do? Doc, what's my next step?
Advise the patient on like healthy eating and exercise.
I eat salad with every meal, exercise 5 days a week, get my pulse rate up to blah, blah, blah. Which of course, you know, that's something somebody says in your clinic, there's a high index of suspicion, but nonetheless, that's what you're given. Potential etiologies for this and what laboratory workup you're going to consider here for Mr. Costanza.
You should probably do like a testicular exam.
Okay, normal.
Do blood work for like metabolic syndrome, like blood glucose or triglycerides or other lipids?
Triglycerides, lipids. Lipids are, they're high, but you know, whose aren't at his age? What else did you want? Blood sugar, normal.
Ask about changes in vision. You can think of a brain tumor.
Okay, no changes in vision, no blurred vision, no diplopia, no other neurological findings.
You should probably like do an extensive review of like anything the patient is taking in case there's like exogenous like estrogens or anything like by accident.
Right. No herbal therapy, no supplements, no medications. Again, not sure patients being totally truthful here, but that's what we have. Here are some abnormalities on the abdominal exam. Looks like there's an engorging of umbilical veins.
Ask about drinking history. Really strict alcohol.
Doc, I'd rather not talk about it. It's in my past. Last drink 4 days ago.
Try to get them to talk about it. a
What?
little more.
Well, you're gonna,
Do some like
you referred me to that Tobia guy. I'll talk about it with him.
liver labs.
Okay, so we have abnormal liver labs. Okay, so what do you think in the etiologies here?
Cirrhosis.
Yeah, I mean, that would be a concern here. I mean, liver failure can certainly result in gynecomastia. All right, so again, underlying medical condition. Now, there's some heritability with alcohol use disorder. Frank Costanza does not demonstrate any aspect of alcohol use disorder, so we're certainly having some creative liberty with this character. And similarly, George Costanza does not demonstrate any aspects of alcohol use disorder, but with gynecomastia, you'd have to be concerned about that, especially because of the heritability if we are focusing on George, right? So I think from that perspective, that's a clinical consideration here. Right? What are some other aspects of liver failure that you might pick up on physical examination? So patient not forthcoming with their history. Maybe they don't abruptly tell you, I'm not going to talk about it to my past. Maybe they say no. Maybe they cage 0 out of 4. Are there any other physical exam findings that might allow for an increased or high clinical index of suspicion about a history or current alcohol use disorder, or active, I should say, alcohol use disorder? Yeah,
Palmer erythema.
palmar erythema. So, and that might be more consistent with gynecomastia, and that both probably have estrogen and testosterone as underlying causes, right? Sex hormones. Anything else?
Spider veins.
Right, spider veins, esophageal varices, splenomegaly. All right, so, all right. So none of which, again, we really find, or Larry David had he revealed in Frank's case. But certainly, I think the discussion of gynecomastia allows for a discussion of that mental disorder, if you will, alcohol use disorder specifically. More about the paranoid personality disorder, getting back to George. Again, so he interprets and individualizes, personalizes neutral comments, which again is very consistent with paranoid personality disorder. This is a condition that is defined by a cardinal feature. So an individual with this condition will demonstrate a pervasive distrust and pervasive suspiciousness of others. All right, so and then if you look at the DSM criteria, they're nothing more than examples of that cardinal feature, which then should make it readily recognizable, identifiable on any shelf exam. What are the other two cluster A personality disorders?
Schizoid.
Schizoid, all right. What's the schizoid personality?
Like they don't have friends and they don't want to, is how I think about it. Like they're kind of isolated, and they like it that way.
Exactly
Keep
right.
to themselves.
So there's social inhibition and the being content, being socially and emotionally distant from others. Schizoid personality disorder. Schizotypal personality is the final cluster A personality. How does a schizotypal personality differentiate from the schizoid?
It's not eccentric.
Odd and eccentric, right? And give me an example of an eccentricity of behavior.
Like the way you dress.
Sorry?
Like dressing in a way that's like abnormal or not something that's like mainstream.
You think that they're like everything has like a meaning, like it's different signs, and you tell people about it.
And that's called magical thinking, right? Which comes up very frequently on shelf exams, right? So schizotypal, schizoid, and paranoid personality, all three of these conditions are considered to have increased risk or propose increased risk for developing a future psychotic illness, including, but not limited to schizophrenia, right? Schizoaffective and delusional disorder as well. So if an individual at a younger age demonstrates aspects of any of these cardinal features, they are at increased risk for developing adult schizophrenia or another psychotic disorder as an adult. Questions about cluster A personality disorders? I don't think George has a cluster A personality disorder, but certainly his behavior in this episode allows for a discussion of those three. Anything else with George? What's the defense mechanism of paranoid personality disorder? What allows someone to interpret others' thoughts, other statements as harmful, malevolent, attacks on their character?
Like splitting.
Splitting, there might be some splitting. If you're going to see this on an exam, it is much more likely you're going to see splitting in the context of borderline personality disorder. So all or nothing thinking. The reattribution or misattribution of one's impulse onto another. So instead of acknowledging, I hate him, he hates me, he has it in for me, is projection. Okay, now projection could be adaptive. And, if it is adaptive, it's usually because the individual is flexible when they use projection. And then when they use various others. So the flexibility and adaptability in using defense mechanisms really is the hallmark of whether or not something is functional versus dysfunctional. However, when an individual becomes fixed and rigid with regard to their singular use of any one defense mechanism, projection being just one example, that's when there's risk. So the individual that only uses projection, for whatever reason, certainly is at significantly increased risk for developing the paranoid personality disorder, right? So the misattribution of one's own id impulse onto another so as to avoid acknowledging that impulse. You cannot allow that thought to come to conscious awareness because the superego will not allow it. It is much more socially appropriate superego reality principle that they hate you rather than acknowledging I hate them. That's projection. Now, if an individual develops paranoid personality disorder largely because of the maladaptive or dysfunctional use and utilization of projection, then you could see how they might be one step away from developing a future psychotic illness. Because once you actually lose the cortical override, you lose the protection of keeping that defense as a subconscious process, right? So, I guess it's oversimplified, but if you have an intact cortex, this defense, albeit maladaptive, remains just a defense, and then you stay, quote unquote, only as paranoid personality. When the cortex is compromised, you could have psychosis. So for example, if you drink too heavily one day, that cortex can be compromised and you can actually have a psychotic episode. Now, this might be deemed substance induced, but you can see the mechanism. Schizophrenia has hypoperfusion of the cerebral cortex, and that's not reversible. So if that happens, you'll lose that cortical override, and then projection evolves to frank paranoia, which of course can be a delusion, which of course is defining of schizophrenia and other psychotic illnesses. So that's the very oversimplified kind of progression of how a defense can start as an adaptive, functional, subconscious process, all the way to first break psychosis, perhaps onset of schizophrenia. Anything else about George? What are the characters you want to discuss this morning?
Jerry also, I felt like kind of tying into the paranoia, was paranoid about the doorman. He thought like immediately that the doorman like didn't like him and was suspicious of him. And then the like biggest scene for me that demonstrated that was when he like, there was like a delusion of him seeing the doorman and his doorman friends like laughing about him.
Yeah.
And I don't know how much truth there was to it because the doorman did act a little like, you know, standoffish and stuff, but I don't know. I felt like it was definitely somewhat paranoid.
So if we think that Jerry is demonstrating an aspect of paranoia, and therefore we're saying that Jerry appears to be utilizing the defense of projection, what would his impulse be? Did we hear Jerry say or make a statement related to, he doesn't like me? Would we be surprised if Jerry disclosed that doorman, he's got it in for me, he doesn't like me? Right? Not at all. So what's really going on? What's Jerry's true impulse? What is this ad really saying?
He feels guilty about what he said about Doorman, I think.
The id never feels guilt. No, the id never feels guilt. If you ever watch an animal in a safari, you're seeing true id. There's no guilt. If that animal does in front of you with the other animals, I feel like the other doorman, the other animals, you'll never see that animal look at you and then shy away in guilt.
And then he's projecting and he really just doesn't like Doorman.
That's exactly right. Right. The id, Jerry's id is, I don't like him.
Mhm.
Right. That's right. That's what Jerry Seinfeld's about. All right. Now, again, the etiology of that, we have no clue, zero clue. But if we're going to operate along the lines of psychoanalytic theory, by Jerry having this fantasy of the doormen laughing at him, we can actually take that as the id impulse of Jerry Seinfeld, that he does not like this person. But his parents probably instilled values, built this superego, which will not permit or allow Jerry to have that thought come to conscious awareness. It's not right. But that's the superego. That's where guilt is for all of us. Right? Guilt for Freud equals anxiety. right? And anxiety is nothing more than that friction between one's superego, largely due perhaps to Mr. and Mrs. Seinfeld, at least originally, and the id impulse, which again is governed by the pleasure principle. Eating, sleeping, sex. That's it. That's the id. Merging Maslow's theory with Freud's. Anything else with Jerry?
He was like changing the times of the movie to avoid having to interact with the doorman. He's like going to lengths to change things in his personal life to just avoid that interaction.
Yeah, I mean, so we kind of, if we're operating that Jerry is using projection, utilizing projection, he might also concurrently be utilizing avoidance behavior or avoidance as a defense. Now, there seems to be a conscious component, but we could certainly discuss avoidance as an adaptive versus maladaptive defense mechanism demonstrated by Jerry Seinfeld, the character in this episode. Avoidance. Of course, if we're gonna, and again, I'm not gonna apply this to Jerry per se, but if we see someone in clinical practice that presents with avoidance behavior, and that avoidance behavior is clinically significant, that is, it's causing the individual clinically significant distress or impairment, we may be diagnosing, or at least having our differential diagnosis, avoidant personality disorder. So avoidant personality disorder is just that. It's avoidance behavior that is clinically significant and pervasive, defining who the person is. Very difficult, maybe upon first interview, to differentiate avoidant personality from the schizoid personality. How? Because both are avoiding, both are socially isolated. What is the single biggest difference that is likely to appear on a shelf exam that allows you to choose the correct answer?
Being content with being isolated versus feeling distressed about it.
Yeah, that's exactly right. And because of that, and this is what you need to look for in your shelf exam, individuals with avoidant personality disorder are conflicted because they do want to put themselves out there, but they don't feel as though they could, right? They're socially, they feel socially inept, and therefore they avoid other people despite the fact that they do want to interact socially. They are much more likely to be self-referrals. So that's a clue for your shelf question. Individuals with schizoid who come to clinical attention are usually not self-referral because they're perfectly content. It's that they're living in the woods and maybe a third party takes them in for evaluation after, let's say, for example, the police or the health department discovers what's going on, right? So third party referral, you think schizoid personality because individuals are content in what they're doing. And that's different than someone with the avoidant personality disorder. Anything else? A couple minutes before the bottom of the hour.
I also thought it was interesting when Jerry, like almost seemed to try to ease his anxieties by like taking the place of the doorman, by trying to make him like him and trying to like kind of work to yeah, like be liked by him.
Yeah, the lengths he will go to be liked. What do you think's governing this?
I don't really know that much about Seinfeld in general, but he seems like, I'm not, narcissism may be the wrong word, but he seems to have like an element of very, very high self-regard that I think is related to it because he can't take it when other people don't also hold him in that high regard. Just like the few episodes I've seen.
That's absolutely right. What do you think that comes from? Where does it always come from? Yeah. When in doubt. When in doubt, your parents. Absolutely, 100%. And by the way, Mrs. Seinfeld has on more than one occasion verbalized, who wouldn't like you? Everybody likes you. Everybody has to like you. Who doesn't like you? Right? So we could get an idea of what that might be like for 4 or 5-year-old Jerry Seinfeld. Okay. So when he has these interactions with the doorman that he has, that superego is very active, and hence the guilt. Okay. So we see behavior in his trying to undo that. Now, I don't know if I'm using undo correctly here as a true defense mechanism, but you see that he's trying to reverse that. And his need to reverse it is likely because of his superego, and that's likely because he's hearing the little voice of his mother in the back of his mind, that he should be kinder to people. And that way people can regard him in the favorable way, the way she regards him. So probably now, again, only if this comes to clinical attention would this be addressed. If he's doing the things that he's doing, altruism, which again is a defense mechanism, and it's not causing clinically significant distress or impairment, then we leave it alone. But if Jerry comes and says, listen, I need help with something, we might be talking about Mrs. Seinfeld here. I don't see Mr. Seinfeld as being that nurturing and being or building the superego with that respect, with this specific issue, as much as we see Mrs. Seinfeld's behavior, albeit in other episodes, resonating with Jerry here. Any final thoughts or questions? All right, we'll leave it here. How are we generally speaking with follow-ups? Are we almost ready to go?
Did we only have the one? Yeah, we only have one.
Yeah.
Can we get a few more minutes?
Absolutely. How many minutes you need?
Like 10?
Sure.
10 minutes.
We'll be back in 10 minutes. See you everybody
Thank
then.
you.
You got it. Thank you.
I went to see